Okay, thank you. I'd like to thank the Prader-Willi Research Foundation for letting me come and speak today. So I'm going to talk about some preliminary results from a PhD thus far. I'm second year, and this is about understanding ventilatory control in children with Prader-Willi syndrome. Now to start, I want to give a bit of a summary of what I'm going to talk today. So the craniofacial features of children with Prader-Willi syndrome, together with low muscle tone and the risk of obesity, predispose them to obstructive sleep apnea. Now in children, obstructive sleep apnea is primarily due to enlarged tonsils and adenoids. Now importantly, growth hormone may cause the tonsils and adenoids to grow. So therefore it's important to check for OSA before growth hormone therapy and again afterwards. Now my research is investigating how breathing is controlled in children with Prader-Willi syndrome and the potential impact of growth hormone. Now, sleep has significant effects on the cardiorespiratory system. Now, importantly, the control of breathing is dampened during sleep. Now, when we sleep, the muscles in the upper airway relax, making them more prone to collapse, causing pauses in breathing or apnea. Now, when this occurs, this is called obstructive sleep apnea. But there's also another form of sleep disordered breathing, which is called central sleep apnea. But to start with obstructive sleep apnea, this happens when the upper airway is blocked and we're still trying to breathe. But because the airway is blocked, we have limited or completely blocked airflow. Now in central sleep apnea, this is not usually the case. The airway isn't blocked. The reason there's no airflow is because we don't have the drive to breathe. So because of the predispositions I mentioned before, children with Prader-Willi syndrome have a much higher prevalence of obstructive sleep apnea compared to typically developing children. And this is also the case for central sleep apnea. Now, an important aspect of my research is surrounding growth hormone. Children with Prader-Willi syndrome have reduced growth hormone secretion, and this is because the hypothalamic pituitary axis is not working properly. Now, because growth hormone is important, especially during childhood, they are treated with growth hormone therapy. This improves growth and body composition and also motor function. But a potential negative side effect is enlargement of the tonsils and adenoids, which can lead to severe obstructive sleep apnea. Now, because of this risk of obstructive sleep apnea development, to pay for growth hormone therapy, the Australian government requires the children to undergo 2 sleep studies. So one before they start growth hormone and another after growth hormone commencement, which is usually around 6 weeks. Now in contrast, growth hormone has been found to improve central sleep apnea, and this is thought to be due to an improvement in ventilatory control. Now when I talk about ventilatory control, I'm referring to the mechanisms in our body that regulates our breathing. Now during sleep, this is achieved by a negative feedback loop, where the main driving factor for ventilation is chemical control, being oxygen and carbon dioxide. Now before I start losing everyone in some of the terminology I'm going to go through, I want to briefly explain what a negative feedback loop is. Now, to do this, I'm going to use the climate control system as an example. And today we're probably going to use a heater because it's bloody freezing. So when we set a temperature, let's say it's 22 degrees, and the temperature gets too low, this is picked up by a sensor which tells the air conditioner to increase in temperature. Then when we get back to a stable temperature of 22 degrees, this feedback loop stops. But if the sensor's not working properly, so let's just say for example it's too sensitive, it's going to keep telling the air conditioner that it's either too hot or too cold, and it's going to constantly blow out hot and cold air and defeat the purpose of the system. Now getting back to ventilatory control, we can assess this using the engineering concept loop gain. So loop gain is a term used to describe the sensitivity of any system controlled by negative feedback. Now I'm going to talk about the feedback loop involved in ventilation. So instead of temperature, we're now talking about a ventilatory disturbance, and this could be an obstructive or essential event. When we have a disturbance in ventilation, this causes a change in blood gases. This is picked up by our sensors, which are chemoreceptors, and this results in a ventilatory response. Now, again, if these chemoreceptors are too sensitive, then the ventilatory response would be disproportionate to the ventilatory disturbance that's eliciting the response. And this is what we're suspecting is going on in children with Prader-Willi syndrome. Now, in short, loop gain is a ratio of the corrective ventilatory response to the ventilatory disturbance. And the quantification of this ratio tells us about the stability of the ventilatory system. So for example, if someone has a low loop gain and experiences a disturbance like an abrupt increase in ventilation, they'll have a small response to oppose the disruption. So their ventilatory response dampens out and their breathing ends up stabilising. But when we contrast this to someone with a higher loop gain, the same disturbance will cause a much larger response. This response increases in amplitude until we get these cyclic oscillations in breathing, similar to what we see in obstructive and central sleep apnea. Now for this study, we aim to establish whether growth hormone treatment affects sleep and ventilatory control in children with Prader-Willi syndrome. And we're hypothesising that growth hormone treatment will increase ventilatory control stability and reduce the number of central respiratory events. Now I've given a bit of background about loop gain. I want to briefly explain how this method is put into practice. So in adults, obstructive events are used as the disturbance we measure the response to. But these events are considerably less frequent in children. So because of this, we use spontaneous sighs as a disturbance we measure the response to. Now in sleep studies, we measure airflow, which is the nasal pressure from the nasal cannula, which was previously explained. And we use sighs, which are at least double the amplitude of baseline breaths. And we use the breathing effort bands to confirm that the sighs are indeed a sigh. Essentially, what we do is we look at the airflow trace and identify spontaneous sighs during non-REM sleep. So from our database, we retrospectively identified 67 children who were under 18 years old, and we had, with consent, to use their data for research. From these, we had to exclude 30 of the children because they didn't have a pre or post growth hormone study, or because the study was before December 2010 and sadly wasn't available. So this left us with 37 children. But because nasal pressure and having a spontaneous sigh is crucial in the loop gain method, 22 of these children had to be excluded, which left us with 15 children to do this preliminary analysis on. Now to start going through the data, with the demographics, the sex of the children was equally distributed and the children were around 34 months old. On average, the children were 90 centimetres tall and weighed around 16 kilos. The BMI Z score was 1, and together these growth parameters tell us that the children were within the healthy range. So the time between the studies, being the before and after growth hormone, was about 6 months. So in this table, we've got the typical variables of sleep characteristics. So we've got the total sleep time, sleep latency, how efficient their sleep was, or sleep efficiency, REM latency, their wake after sleep onset, which is how many times they've woken up during the night, and the time in different sleep states. On the right, NS stands for non-significant, so the difference in pre and post was non-significant. So because we were also interested in ventilatory control and sleep disordered breathing, we also investigated the respiratory characteristics. In particular, we looked at the indices of sleep disturbances or arousals and markers of saturation. Similar to the sleep characteristics, we didn't find any difference in the respiratory characteristics. So getting to more of the crux of my research, we have the OAHI on the y-axis, which is the obstructive apnea-hypopnea index, which is just the number of obstructive events per hour of sleep. You can see that we've separated the severities by colour, normal being less than 1 event, 1 to 5, mild, 5 to 10, moderate, and greater than 10 events per hour is severe. On the left and right, we have the black bars here, which is the median and IQR, which is just describing the spread of the data. And overall, pre and post, we didn't find a significant difference after growth hormone. We can see that majority of the children were within the normal range. But we can see that this one child had mild OSA before and after growth hormone. But what stands out is this one child here who had no events before growth hormone and developed moderate OSA afterwards. So in both of these children, because of either the development or worsening of OSA, they both stopped growth hormone as a result. So now we're looking at the central apnea-hypopnea index, and in children the cutoff is 5 events per hour of sleep. Similar to obstructive sleep apnea, we didn't find a significant difference after growth hormone. But as I'd like to point out, is these 4 children had central sleep apnea before growth hormone, normalised afterwards. Now, when investigating loop gain before and after growth hormone, revealed no overall significant difference. But we can see there's quite a lot of variability. Some children didn't really have much of a change, some decreased and some increased. Because of this variability, we wanted to see if the change in loop gain was associated with the change in the OAHI, or the obstructive apnea-hypopnea index, and the CAHI. We can see by the R and P values that we did not find an association. So, in summary, following growth hormone treatment, sleep was unaffected. Central sleep apnea improved and OSA developed in a subset of children. And in contrast, growth hormone did not significantly impact loop gain. The change in loop gain was not associated with the change in OAHI or CAHI. Although no significant difference in loop gain was found, we're still collecting data from our database and from our national collaborators in Perth and Queensland to increase the sample size. So we'd like to thank and acknowledge all the parents and children who participated in this study and the staff at the Melbourne Children's Sleep Centre where the study was carried out. We'd like to thank and acknowledge the Prader-Willi Research Foundation Australia for funding this project.
Thanks so much, Okkes. I have a question, but I'm going to see if anybody else does before I ask mine. So it's a small sample size, but is there anything that can help you work out those children that responded versus those that didn't? Is there anything that you can stratify just by looking at the data that you have?
Not with the current sample size, it is too small. So if we use that one child as an example that had no events before and then developed, quite a lot of obstructive events after growth hormone. I did look at the loop gain in that child, and there was no difference in his loop gain after. But of course, the sample size of 1 is very good.
And do you have information like whether they're patients with a deletion versus UPD? Is there anything from the genetics that might tell you something? I'm always hoping it's genetics.
Not that I'm aware of, but that is data we can look at.
Going to the second Marnie in the room.
I do actually wonder whether that one child was mine. Maybe not because your age is, he was quite young, but we had exactly that. So no obstruction, started growth hormones, obstruction,
Yep.
further severe, and then removed adenoids and a supraglotoplasty throat surgery and
Yep.
0 obstruction.
Afterwards?
Afterwards.
Yeah, that's good.
Yeah.
Yeah.
So I was just wondering, do you then, again, small study, but do you correlate or follow those to then see was any intervention taken and then resolved?
So when you say intervention, are you referring...
So in my son's case, the intervention was surgery,
Yep.
ENT surgery, which then was subsequently resolved.
Yep.
And then my second question is, I think you kind of raised it, you don't know when it's a small sample size. Is that of the typical population, if you took those age, small babies or young children
Yeah.
and potential adenoid growth,
Yeah.
could you see that in the normal population of 1 or 2?
Yeah, absolutely. Enlargement of tonsils and adenoids is the leading cause of obstructive sleep apnea in all children. And adenotonsillectomy, like getting rid of the other tonsils or adenoids, is the leading treatment. So it is good that there was very high resolution. Now, my study in particular, I didn't go too much into details about it, but for obstructive sleep apnea, there's 4 main causes. So obstructive So a child or an adult has to have some sort of impairment of the upper airway for it to cause, but someone might have a slight impairment of the upper airway, and they might have a really low arousal threshold, which makes them easier to awaken. They might have an unstable ventilatory response, and they might have a poor muscle innervation. So a child might not necessarily have too much of an obstructed airway, but can still develop obstructive sleep apnea. So that's what we're trying to ascertain, is if that's the case in these children. I hope that answers your question, sorry.
I was just going to say, because Angus has sleep apnea, but he had his tonsils and adenoids removed prior to growth hormones. That was part of the deal that he had, because they were enlarged anyway. But it didn't change a thing. He still has obstructive sleep apnea. Yeah, so that comes back to, again, he still might have some enlargement of the upper airway, or highly collapsible upper airway because of poor muscle innervation, and then along with the poor ventilatory response, you might be really easily to arouse from sleep and all that other sort of stuff, which is contributing as well.
Thank you very much, Okkes, and we'll move on to the next talk now.